Good afternoon and welcome to this panel discussion, this policy briefing. How many people care about children? And how many people care about mental health? Then you are in the right room. Thank you for coming, especially at this hour, because you have had a number of sessions earlier. But I can tell you this is one of the most important sessions because you will have a chance to listen to a number of people who have had a number of years of experience in this area. But more importantly, you will have a chance to share your own experience. So we will have an initial round of questions asked to the panelists, but you will have a chance to ask them questions as well as share any experience that you would like to. So let's begin. I would like to invite my panel members to join me here. And as they come, I would like to introduce them. Dr. Agnes Binangoho, she's from Rwanda, Vice Chancellor of the University of Global Health Equity, a pediatrician by training, and an ex-Minister of Health, Rwanda. Agnes, you're most welcome here. Dr. Sviatoslav Dovnia, child neurologist, co-founder of St. Petersburg Early Intervention Institute from Russia. Professor Lauren Kenworthy, Director of Center of Autism Spectrum Disorder, Children's National Hospital, George Washington University, USA. And last but not the least, somebody from Qatar, Professor Muhammad Waqar Azim, Chief Department of Psychiatry, Sidra Medicine, Qatar. Two women, two men, sitting separately. Thank you.
So now what we should do?
I will just have to stand.
I think if she's going here, I think we can spend 10 minutes to find
Yeah.
Okay, let's get on with the work. Let me just say a few words about the importance of this area. And I'd like to begin by recognizing that the Sustainable Development Goals of United Nations, adopted by all countries in 2015, have included mental health and well-being as a component. That is a belated but very appropriate recognition to the fact that for human beings, mental health and well-being matter a lot. And the second fact is that a lot of determinants of mental health and well-being are in the early periods of life. It begins even before a child is born, but after that, the early years are extremely important. And also the next critical phase is the adolescence, where a lot of other damage can be done or protected from. And all of this really goes towards the fact that what you do or what you don't do during the childhood and adolescence matters a lot for the mental health and well-being throughout life, including in old ages. So the question is, what are we doing about the mental health and well-being of children? How good or bad we are, and how can we improve that? We have a number of people here who have spent years and decades working in this area in their own countries, but also internationally. So we want to share the experience of what works, what doesn't work, what can work better, and what the governments can do, what the civil society can do towards improving mental health and well-being of children everywhere. Because as the SDG says, as was highlighted in the morning, the motto is not to leave anybody behind. And the fact is that we are leaving a very large number of children behind, not only in low and middle income countries, but also in high income countries. So when it comes to mental health, we are all living in developing countries. However rich or poor may be, however small or large country might be living in, we all have a lot to improve. And this is what we are going to discuss today, so that we can have policies which are much better, we can have actions which are much better, and we can serve those who are not being served right now. Let me also say that services does not mean treatment. Services means promoting mental health and also preventing mental disorders, which are especially important during childhood, because stigmatizing by labeling is something that we don't want to do. So the importance of promotion and prevention, especially during childhood, is extremely important. The other fact is that although we say mental health, it is much larger than health. It involves a number of sectors, health certainly, but also education, child welfare, and many other sectors, and they all have to contribute. So it's truly a whole of the government approach that we need, and that's where we have to marshal all of our arguments to make an impact on those people who don't realize that by their actions they might be harming the interest of children, or can, on the other side, improve their situation very much. With that introduction, I would like to get into, well, one more thing. I have this book in hand, which is the Lancet Commission on Global Mental Health and Sustainable Development, which some of you at least know was launched a month back in London. And some of the commissioners are here. 28 commissioners worked for 3 years to produce this report. There are some copies which are available. It's also on the website of Lancet, and you don't have to buy it. It's available free on the PDF file. The key messages of this commission are that mental health and well-being is important, but enough resources are not being spent on this anywhere in the world. And so we need more investments. The second message is that mental health of children is especially important, and we need to make a very focused effort towards investing in children so that the mental health throughout the life course can improve. And there is a lot more research necessary on that, but already we know enough to make a large impact. So it's not that we just need to know more, we also need to act more, because knowledge is there for us to be able to impact. And we have 4 people who will share their knowledge. So let's get on with a few questions that I want to ask. I like to begin with Agnes, you, since you have had the experience of being a policymaker, but also a researcher, and having a very close interaction with the children as a pediatrician. So I want to ask you, what is the role of the different sectors, health as well as outside, in helping children to have the best mental health and well-being, in keeping with the international focus on sustainable development goals, but also on human capital index, which has been promoted by the World Bank, and the social capital concept that is gaining ground? And how is Africa doing compared to other regions, and how it can do better? Agnes.
Okay, no, we have one here for you can share. Good afternoon, everybody, and thank you for having me here. So there are many questions in your question.
But you have only 5 minutes.
Okay, so let's run. First of all, how can we do for the children? We should never forget to adapt all those great concepts to the national culture and to the meaning of a blink of the eye, a smile, and everything. And for children more than for adults, because they are voiceless. In general for health, but for mental health too. So now concerning the SDGs, mental health is there. It's almost the first time. It has been neglected nationally, but globally even more. For the first time this year, there is an office at the World Health Assembly. Can you imagine that? Thanks to Tedros, it's the first time. And there is only 2 people. So there is a lot to do, this globally. Now, for the human capital index, the link with mental health is not direct at all. You have the human capital index that is good. It allows to measure what governments are doing for health and education. We are going to mark them, etc. And on the other hand, we have the social capital. We have the human capital index, we have the social capital index. We should not separate them like I do with my hands, but they are not the same at all. The social capital assess more the bond we have. And it's so important in mental health. And I'm going to give you an example. There was a great study done by a team of anthropologists in Harvard studying why in many countries in Africa there is better compliance to HIV treatment. What is the most chronic disease we can have that you are healthy but you have to swallow tablets every day? All chronic diseases go with depression. Why in Zambia and other African countries, people were more compliant than New York and Paris? Social capital. Social capital is higher. And if you look now, the human capital index in those countries compared to New York and Paris, they are low. You see? And in case of depression, social capital, for me, I count more on that than human index capital. So there is a difference that counts, and we should study more as researchers, and all the big players and experts at the World Bank and World Health Organization should explore more. Because human capital index, social capital, we expect that the social capital is the summation of the human capital. It's not. And for mental health, go for the social capital, guys. So Africa is low because of lack of money for having the same type of education and the same type of health sector. But when you are depressed, you don't care that you have the best fibroscopy access the day you need it. What you need now is somebody you can hug and where you feel good. You understand? So for human capital index, I can give you the data because I look at them before coming here. And you have, if I found them, I should have found them. And of course, I will not find them. But you have like Qatar is 0.6, US 0.7.5, Germany is 0.7.9. Rwanda, Zambia, and all those countries are half of that. However, there is something that is better. I don't know if I was clear in my answer.
You were very clear. You were saying that social capital is more important than the human capital index as defined currently by the World Bank.
Absolutely.
And that point is well taken. But
however, keep it to measure the investment the government are doing in the health sector and education sector, because it will help more development, but the problem with development is you lose most of the time social capital. So make the two work together and make sure that government or countries make the effort to keep what make your social capital great when they develop your human capital.
That's excellent, because what you are saying is, don't go just for economic development, don't go just for human development, go for social development also. Point excellently made. Hopefully many countries in Africa are listening to you as you are speaking now and will follow that.
Yeah, 4 of the fast growing countries are in sub-Saharan Africa economically. So rendezvous in 20 years from now.
Thank you so much. We'll come back to the points that you raised again, but let me go on to Slab now. You've written a lot, and you have worked a lot in supporting vulnerable families in child development. That's your area of work. And you have already achieved very many successes in Russia, but also in other countries. What are the key lessons that you have learned that you would like to policymakers to keep in mind as they plan further actions in this area all across the world?
Yeah, thank you. It's very difficult to summarize in 5 minutes. But I will try. And there are a lot of successes, but there are a lot of cases when we didn't achieve any success. And actually, I'm with my colleagues working in an area when we are trying to establish the new type of the services based on evidence-based strategies and build something which weren't exist before we started that. And there are few messages I would like policymakers to keep in mind. First of all, I want to kind of stress that please support evidence-based strategies, because it could be really sad if in a few years you will recognize that something you invested doesn't make any sense or difference in the people's and families' lives. And that's quite common situation when the people are investing a lot of time and money and resources, and when finally they are coming to the point that they need to start from the zero level because there is no changes in the real life. Try to avoid situation when you will be financing or funding, like a double funding the existing old-fashioned services and the new evidence-based services, because this replication of the resources could be important reinforcement for people who start to develop something new. And if they will see that they actually can do nothing and get the same resources, that could be very, very disappointing for them. Very important thing for me, there is no evidence-based strategy for the low-resource countries. That doesn't exist. If it works everywhere. So it could be cheaper solution, but it couldn't be different solution. You wouldn't find something special and cheap for the countries who don't have money. So you need to be kind of open-minded and honest and say, yes, to achieve the same results, we need to do something similar. Another thing is resources are important, but the human resources are super important. So don't hesitate to invest in the people and the people's education. But remember that the seminars and lectures, they actually don't change the real practice. So if you are investing in something, invest in the creation of the new type of the services which could be a clinical basement for the future praxis for those who are educating during the lectures and seminars. So then you are investing the funds, spend funds for this, creating the services, not just providing the lectures by the foreign experts. And and the last thing I would like to repeat, try to relocate resources as soon as it's possible. As soon as you decide that you are starting something new, for autism, for depression, for any type of the services which is kind of we know works better than the old-fashioned models we traditionally used. Try to relocate money, resources, staff, everything you have. That's it.
Thank you, thank you. You have raised a number of points and given a number of key messages, the importance of evidence, the importance of human resources besides financial resources, but also the fact that you should implement only those interventions which have proven to be effective in that situation. So that some work might need to be done in regions where enough evidence has not been collected. That's excellent, and you have worked in middle as well as low income countries, so those are very, very good messages for many of these countries. Thank you very much for sharing your experience with us. I come to you, Lauren, and your work on construction and development of interventions and inventories and scales has been well recognized, well reported in the literature for assessment of children with developmental disabilities. How would you see this knowledge being applied in settings where highly skilled service providers are not yet available?
Well, thank you for that question and the opportunity to talk about something that I really care very deeply about. I think, as you just said and Lord Darcy said this morning, in the United States, as across the world, we have a lack of access to evidence-based mental health treatments. And so I've been very committed to thinking about whether there are innovative digital tools that can empower people outside of the medical community to understand and address developmental problems. Most recently, I've had the privilege of working with the Get Well Network to create an app for families of children who are newly diagnosed with autism. And it leverages the latest technology to bring families key information and support as they absorb the meaning of the diagnosis and they build a treatment plan. And I'm really excited about the potential of this tool to help families around the world, because Get Well has plans to translate the tool into Arabic and into other languages. You can learn more about it at the Children's National Medical Center booth in the Innovation Hub. My long-term focus, however, has been on brain-based cognitive abilities called executive functions. And executive functions are associated with most mental health and developmental disorders, including autism and ADHD and anxiety and depression and aggressive behavior. Executive function also arise out of environmental stressors. So, for example, in the United States, we have a population-based study, several, showing that the years that young children spend living in poverty are directly related to their executive functions as they get older. So they drive really important outcomes: employment, academic achievement. Even in the U.S., another large study shows you can predict incarceration rates in adults when you look at their executive functions as children after you control for intelligence and socioeconomic status. So in my mind, they're an important key area to address, and we need to develop both assessment and treatment tools that are accessible to those outside of the medical clinic. So in the U.S., we have a public school system that offers a really rich resource because it is a nationwide network of school staff, and they're mandated to provide services to all children. So we've been trying to leverage that system to improve mental health of children, and basically thinking about ways that we can responsibly give away our clinical knowledge that can be implemented by school staff. As a psychologist, you know, it isn't sort of the nurse in the community, but it can often be the teacher in the school who can help us. And that was the spirit in which I worked with my colleagues to develop the behavior rating inventory of executive function, where we sort of translated our expertise as clinical neuropsychologists into this simple checklist of behaviors. And basically, using that checklist, we can characterize executive functions across inhibition, flexibility, working memory, these key cognitive skills that drive our ability to regulate our emotions and our thinking and our behavior. And we can develop an individualized profile of a child's strengths and weaknesses that then is linked to very simple and direct advice about how to help work with that child most effectively. So a really basic example would be for a child who has brain-based inflexibility, we advise parents and teachers to give them a warning before they have to make a transition or a change. And this very simple intervention can prevent a lot of disruptive behavior, temper tantrums, and meltdowns. So the brief is used in schools and clinics throughout the U.S., and it's been translated into over 150 languages now, including Arabic. I've also developed executive function treatments that can be administered by public school staff. So straightforward school lessons that teach children to be flexible, organized, and goal-oriented. And to accompany these lessons, we've provided trainings for teachers and parents that explain basic evidence-based techniques that are found in the intervention, but that are much broader than that. So, for instance, positive reinforcement techniques. And to date, what we found is that this intervention, which is called Unstuck and on Target, can be effective for children as delivered by school staff who have autism or ADHD. And so in keeping with the recommendations of the Lancet Commission, what we're working on now is providing parent and teacher training modules in this intervention that are online. And through very short videos, we find short, brief little segments that model the key skills are very powerful for moving beyond that sit in the lecture and listen to me talk to this is actually how you can do it, now go try it. So my hope is that with these kinds of tools, we're providing some examples for this kind of next generation of mental health tools that will get clinical knowledge as appropriate directly into the hands of those who can use it.
Thank you very much. So you are working for getting these instruments out in the field in as many languages, in as many countries, to identify problems, but also to take care of problems. And all of that can be done by human resources which don't need to be PhDs, which is very important because we need to give it out in the hands of people who are already there and can use it. And you also specified the role of education sector, the use of teachers, and in many other countries, other people who come in contact with children who can use it. So thank you very much for sharing that information. We go to Waqar from Qatar. Sir, you have developed child and adolescent mental health services in the country extremely systematically and also developed the Qatar National Autism Plan, which is a unique plan in that region, the first one in the region. What lessons would you like to share with others in the region as well as outside the region who are trying to do the same in their countries? What were things that you found easy, but what were things which were difficult?
Sure.
Thank you. Excellent question. Good evening and assalamu alaikum, everyone. I think there are two questions in this, and I will just make a brief correction. It's not just me. A lot of people contributed to both of these causes in the country. So we'll give you a little bit of a historical perspective that I came to Qatar in July 2015. And before me, there was only one child psychiatrist in the country. And there was almost no perinatal mental health services. So the task was to build child and adolescent psychiatric services and perinatal psychiatric services. And I think both are interlinked. And in about 3 years at Sidra, we have full-fledged divisions for child and adolescent psychiatry and perinatal psychiatry. And our total staff is about 30 right now. So we have come a long way, and our encounters are in thousands for this year for both services. So I think both of my teams have played an important part, an amazing part in building these services, along with the two most important stakeholders, HMC and PHCC, who are very important stakeholders in building these services. Secondly, going to the National Autism Plan, Qatar is the only country in the region which has a National Autism Plan. And a lot of people work together at least for 2 to 3 years to build this plan, which is based on certain pillars. One is awareness, second is screening, third is diagnosis, fourth is interventions, fifth is role of schools, and sixth is transition to adulthood or adolescent and elderlyhood. And there are a couple of, I think, examples which are worth mentioning. One is that we didn't use the word children in the National Autism Plan because we have a lot of adults in the country who have autism, so we use the word individuals. And secondly, I witnessed such a powerful meeting in February 2017, which I can't imagine happening anywhere in the world, where there are 6 ministers sitting, chaired by the Prime Minister, and there are 9 families, and every parent explained the story of their child one by one with some of the stakeholders. Can't imagine happening anywhere in the world. I still get chill when I think about that meeting. So a lot of people have asked me, especially regarding National Autism Plan as well as building services, what are the main reasons for success? And at least there are 3 things come to my mind. Number 1, country's top leadership behind these causes and have a vision, including Her Highness Sheikh Hamoza bint Nasser, the Father Amir, the Grant Amir, all the country's leadership, Minister of Health, Dr. Hanan Al-Kawari. All these folks have played a huge part having a vision in building the services for the country. That's one. Secondly, regarding National Autism Plan especially, all the stakeholders from around the country worked together for about 2 to 3 years to build the plan together, which I think was instrumental in making it successful. And last but not the least, parents and families not contributed, actually led some of the parts of the plan. So those 3 things, I think, played a major role in being successful in this country.
Thank you very much. Very important lessons here. The involvement of the leadership in the country, but also the involvement and contribution of the parents and individuals who have these disabilities. As they say, nothing about us without us, and that applies equally well to the policies and the plans. That's an excellent example of involving the families in development of the plan, and then that leads to the success of the plan. Thank you very much for sharing that. Let me have a check on the time. We are 4:37. Over to the people in the room. I would like you to ask questions to any of the panel members or to share some experiences, but briefly so that we can involve as many of you as possible. So I suggest not more than a minute. Do identify yourself and pose the question or the comment, and then we will take 3 or 4 of them, come back to the panel, and this continues till the time we have time. So I already have 3 names. From that side, we begin with Afzal, then the lady, and the lady here, please.
Good afternoon. My name is Afzal Javed. I'm a psychiatrist and currently president-elect of World Psychiatric Association. Thank you very much, Professor Saxena, for leading this very important policy briefing. My question to all the panelists is that they have very comprehensively explained what are the factors or the determinants that are important in terms of child mental health, well-being, and development. Apart from that, what they have described, I wonder if they could comment on the role of religion. There are many cultures, there are many countries where religion plays, if not a negative role, a positive role. When I was a student, we were told 2 things are important. Family gives you a sense of belonging. Religion gives you a sense of direction. What do you think in this changing world? What are the roles of these, and whether the policymakers, the professionals, the experts should touch these areas or should avoid these areas?
Thank you very much, Afzal, for raising this issue, which is important for all regions, but especially in the region that we are in. Second question, lady.
Good afternoon. Thank you for your informative and very good panel. I would like to ask you a question about that. As you have mentioned, that everybody's mental well-being begins before birth, during the pregnancy, and maternal well-being affects the fetus and newborns' mental health. What's the? I think that the lack of evidences about this matter, that how this affects, and I think that it would be a priority in the research areas to produce evidences about the effect of maternal well-being, mental well-being on the fetus. Thank you.
Thank you very much. Could you identify yourself?
Yes, I'm Farah from Iran. I'm the head of midwifery office in the Ministry of Health.
Thank you very
Welcome.
much. And there was a question here.
Hello, I'm Dr. Sadriya, National Lead for Child and Adolescent Health Strategy. I have a question. You raised the issue of autism disorder strategy and its related morbidity with the mental health. Locally in Qatar, most of the families who are the autistic children, they don't prefer to belong to the mental health. And in reality, it is neurodevelopmental disorder that can be categorized under the special needs. But again, I can tell you that autism is moving between mental health and special needs. Just I would like to have the thoughts of the panel members. What do you think? Autism spectrum disorder fits more appropriately under mental health or under special needs?
Thank you very much for that question. Maybe one more question. The gentleman at the back.
Thank you very much for this informative panel. I'm Dr. Muhammad Abu Hilal. I'm a Syrian psychiatrist working in Turkey and inside Syria. You know how difficult to live in a situation like the Syrian context. And we even lack resources like as a psychiatrist, but also as child psychiatrist. We don't have only one in Syria, in whole Syria, and now it's very rare to find specialists. Is there any program that we can train for non-specialists so they can treat or deal with children in conflict situations? So we can, help as much as we can. So if you are aware of any of these programs that we can be applied, thank you very much. And also the other thing is like culturally sensitive or related curriculums. Also, if it is available, thank you.
Thank you very much. We come back to the panel now, and I would like to invite the panel members to answer any question that they feel they could contribute to the response. So who wants to go first? Okay, I'll begin with answering the last question, the role of non-specialists, especially in those regions and countries where there is a lack of them, but also a conflict or other situation which has already affected the healthcare system. There are many resources which are available to train people and also to support their ongoing work in doing that for adults as well as for children. And I'm aware of the WHO's work in countries like Syria, in countries like Afghanistan and Iraq, where a short training supported by an instrument called MHGAP Intervention Guide, which is available again on the web, and then support over a period of time has been extremely helpful to identify vulnerable children, to provide the basic skills to the non-specialist provider, including nurses, including healthcare workers, who can do some basic management in a very effective manner. So, as we were discussing earlier, we do not need highly specialized therapists and psychiatrists and psychologists for everything. Their role is clear, they need to help, but they cannot and should not look after every problem. And the whole healthcare system and education system can actually be very, very influential. So I'd like you to look at the WHO's work in Syria, for example, which has been documented and has resulted in very good advancement in spite of the lack of specialists in the country and the region. So that's one example I'm aware of. But maybe there are some other examples which my panel members are aware of.
Yeah. I'm going to give you the example of my country. In 1994, a massive genocide over 100 days, 1 million people killed. So that means there is no family that has escaped in the who was there. But also we have the killers. There's almost all families has a killer. And we have the kids now. So we had at that time 0 psychiatrists. When I say 0, it's not even that they were killed. There were none. We had one foreigner who were more embarrassing than something else because he didn't know the culture. So he was doing the wrong thing by applying some Western method that is normal. Don't put people who come from a genocide in a semi-dark room to make them talk and confidential. No way. So, so what we did, we apply some technique that you can find in WHO, and we train people, even not nurses, we didn't have enough. Even not doctors, we didn't have enough. Civil society people who want to volunteer. And most of them were, for them were a curative way to overcome their own situation. And if you see Rwanda, we managed, today we have 13 psychiatrists, 12 million people. No pediatric psychiatrists, but we function as a country. So those are the experiences that you can come and study, but you will need it because you will have never enough psychiatrists to go to each village and to work there where the people are living. And if you want them to function again in that society, to rebuild the society together.
Thank you very much, Agnes. Let's have responses on the other questions. The question on religion. I don't know who wants to take that up. Or the question on the mental health and developmental disabilities, how they should be classified. In fact, I can have my initial answer to that. The International Classification of Diseases, the 10th edition as well as the 11th edition, does keep neurodevelopmental disorders as a part of what is called the mental and behavioral disorders. But to me, and I think for everybody, the labels should not mean anything. It's the needs of the person which should take the priority. And it's the skills of the provider which should be focused. And we do believe that mental health care providers have a lot to offer to children who have developmental disabilities, whatever name you call it by. So some countries have developmental and neurodevelopmental disabilities included as a part of mental health action plan. Some of them have a different plan. It doesn't matter. We need to have a plan. And that's what matters, really. So I think we should get away and get over this kind of conflict about what to call them. We should focus on the needs of them and focus on that.
I will just add to what Dr. Saxena is saying. I know a little bit of background in the country that it's an issue, especially for the families using the word mental associated with autism. At least from my perspective, where I am at Sidra, part of the National Autism Plan, I think we have some wonderful colleagues in the country who are developmental pediatrics, adolescent medicine, neurologists, child adolescent psychologists, and child adolescent psychiatrists. At least I will support what you're saying. We should be meeting the needs of the children and families, no matter wherever it is. So more important is meeting the needs versus how we classify it. So I think that is probably the most important thing. And I can understand about the stigma associated with it when we use the word mental, especially with these disorders.
Thank you very much. Let's get on with other responses.
Also, if you manage to break the stigma you will not have this fear to go there or there. For the religion, especially when the religion is strong, it's part of your life. And everything which is part of your life is part of your society. And when you don't fit in, you feel that you don't fit in your society, any help is welcome. But you have to reconcile with your religion. You may deny it, but be in peace with it. You may embrace it and be in peace with it. If you are not, you have a problem.
Thank you.
I just wanted to add one point to this sort of the mental versus developmental disability question, which is, I think one of the most important things that I find in my work with families or children or teachers or other doctors is to help folks recognize that there are many behaviors that may appear to be won'ts that are really can'ts. And for many people, it's helpful to frame the difficulty in terms of a brain-based difference. There's a biological difference that makes it difficult for this child to do this thing. So instead of being stubborn and willful and not caring, this is a child who is stuck and has a brain-based difficulty shifting. And to me, that actually applies to many mental disorders as well. But that reframe, I think, is one of those really simple steps that can be fundamental to changing a child's ability to function effectively in their settings.
Thank you.
Thank you. I would like to add one example of the training for those who don't have a high qualification. I think it's interesting program now developing by WHO for parents who have children with developmental disabilities and particularly with autism. That's caregivers skills training. So that could be very useful because it doesn't require the high level of training and specialization, and that's, from our experience, it could be very useful.
Thank you for pointing that out. And in fact, there is definitely a much better need for parents to be involved in the management of children with any kind of disability. In fact, it has been said that we keep talking about not having enough human resources. Parents are the human resources which need to be utilized better, and parents are everywhere. So I think that point is extremely important. So it's not only that we have less skilled formal care providers, we have the informal care providers who are with the child much more time than the formal care providers can be. So that's something which is important. And WHO is working in the area of parents' skills training programs, which will have a tremendous influence on increasing the capacity to look after these problems. Thank you. There was one more question. You want to take it up? Yes, please.
So, I think that was an excellent question about the fetus. Actually, I will go even to mother's health and the fetus. And actually, that is one of the main reasons at Sidra we have perinatal psychiatry division, because both mothers and infant, fetus and infant health is very important. Whether it's attachment, the early attachment now we know can have a huge impact on how the children do on the long run. So I completely agree with you that every country need to have very strong programs, not just for children and adolescents, but for mothers, fetus, and infants.
Thank you. Thank you for adding that. We come back to you, and there was a hand in between, which that time, yes, please. We'll take at least two more questions, so think about what you want to ask.
I'm Satish Girimaji. I'm child psychiatrist from Nimhans, Bangalore, India. My question is on the integration of child and adolescent mental health services, whether it includes behavioral, emotional problems or developmental problems in the primary health care sector. Are there examples of this which have run very well anywhere in the world?
Thank you. Any other question or comment? There are two hands, one on the back and one in the front. So let's take the back one first.
Assalamu alaikum. Actually, I came in the middle of the session. I'm Dr. Ambia Parveen, working as a child specialist. I'm also specialized in neonatology and also child psychiatrist. My question is, it's very nice and generous to hear that that we all should be aware, we all should be available to help people, yeah, wherever it's needed. So even if it is developmental or emotional or any psychiatric diseases, it's good. But if we don't have the professional people, if we are not trained, there is a big chances that we get involved there, like secondary depression or secondary problem. My other questions, people, do you have any idea that the psychiatrist or the social workers involved in conflict zone, do you have any supervision courses for them that they can be aware of, that they can develop, or their symptoms can arise when they face such cases or when they are working with that? Third question goes to the Qatar autism, to the doctor. You have you have talked about the autism. It's a very important topic, I think so. The Middle East and the Asian, some of the developed countries have this taboo, and most of the families still does not accept that. So do you have, like for example, if the parents are not willing or not accepting, or it's very difficult due to the social taboo, do you have institutions, for example, where the children can be taken care, or be that they have the separate houses where they will be taken care of, avoiding from the family stress? Thank you very much.
Thank you. We'll come back to that. Janice, you wanted to ask a question? The lady in the front here, can you raise your hand? Yeah.
Thank you. It's not so much a question, but just to talk a little bit about caregiver skills training and the school health manual in particular as interventions that it can be used in the settings we're talking about. So with the WHO school health manual, we're able to translate that into the Liberia setting, make it culturally appropriate so that school teachers are now in a position to be part of the group that are identifying and supporting kids with social, emotional, and behavioral disorders. And similarly, we're looking at CST, caregiver skills training, for the same reason, because we don't have neurologists, we don't have some of the specialists. And back to your point about can't and won't, I don't think there's a curriculum that helps with that dividing line as much as CST, because once parents have those skills as part of their repertoire, they understand about can't and won't. Thank you.
Thank you, Janice, for sharing that experience. So I come back to the panel. Who would want to react to the question from Satish about the presence of, or the capacity for having child mental health services within the primary care? We did talk about it earlier, but is there anything to add on that?
I know Satish is doing a lot of work on this topic in India, and I know he has done some successful programs on this topic. So India is one of the examples. Of course, he can give the example. But secondly, in states, at least, I'm aware of a couple of states which have developed programs called Access Mental Health, that the child and adolescent psychiatrists are readily available to the primary care physicians, either in person or by phone, and there's time carved out for those programs, especially, for example, in Massachusetts and Connecticut, which is running very successfully. The second thing which I think might be worth mentioning regarding Qatar, when we started our child and adolescent services, in the hospital, it was only physician-based referral, but we did one change, that we will take direct referrals from school counselors. So in my mind, even school is, for child mental health, is even more important than primary care, that we need to be in the schools and working closely with schools to be successful in the country, which at least we have tried, at least right now, that we're working very closely with a lot of schools in the country in that regard.
Thank you, Bakar. Do you want to respond also to the questions
about
specifically
autism?
on autism? Yeah.
So two things. One is actually, I came from states. I'm surprised by the knowledge of families in Qatar. I think they are probably more knowledgeable than the states. and how much they advocate for their children. So I personally have not seen that families shy away from diagnosis or interventions. Secondly, there are some specialized schools in the country, but there is no, to my knowledge, night programs where the individuals stay there overnight. Not to my knowledge.
I would just like to add that the recommendation is that the management of children with intellectual or other developmental disabilities must be done within the families. Although in many countries we do know that there are institutions where some of these children are kept, but that's not a good thing for the child. The best environment for the child is the family. So I think that's something that we must encourage, but remember that we need to increase the capacity of the parents to look after these problems. So it's not that we just leave it to their own devices. The government and health system and education system has a responsibility to provide the support which the families need to look after the needs of the child. So that is the recommendation everywhere.
Just quickly want to add something which might be helpful for the audience. In 2016, we had a WISH autism panel in which there were 11 experts from 5 continents worked together to produce a report for low-income and middle-income countries. And I know it was presented and tried to be implemented in a lot of developing countries. It's freely available on website of WISH. It's a wonderful report. I was part of it. Satish was part of it. There are a lot of other people. I think it's a useful resource. So if you had a chance, go to WISH website. You can download that report.
Thank you.
Just a short comment about the institutional care, because I am from the context where during the Soviet time there were massive development of the institutional care for all type of the disabilities, and it was bad. That was really horrible, and that's a reality we are trying to overcome till now, and we are not always succeeding because that's expensive, and every year child spending in institutional care, spending the overnights life in the institution, creating more and more secondary problems when it will be very difficult to relocate the child or an adult in a familial situation, because there will be a lot of behavioral issues, cognitive problems, things like that. So my strong recommendation, don't create any type of the institutional care when you are thinking about that, because we had this experience and we learned there is no any value in that, only problems and challenges.
And also, institutionalization is against the human rights of people.
Yeah, but that's, I mean, I'm a medical doctor and I'm a scientist, so I'm not really talking about the rights and the love. It's really harmful for the physical and mental health. So there is no question. It's not because I am so human, I don't want the child to be in an institution. I'm a doctor. I don't want to be a child to be sick after the institution. That's my point.
Very well made, but also the UN has the Convention of the Rights of the People with Disability. Also there is a Convention of the Rights of the Child, which both very clearly explain that involuntary institutionalization is not, it should not be done at all. So I think that's both the sides, the scientific side as well as the human rights side recommend the same, that families and communities are the best places where people with disabilities of all kinds must be looked after.
And there are very well designed studies, like a Romanian study, which showed it very clearly. So that's.
Okay. Any further responses from the panel on the questions already asked, or we move on? Okay. Last 1 or 2 questions. The gentleman here.
Good afternoon. I'm Khalid. I'm a fresh medical graduate from Sudan. I don't actually have a question. I would just like to comment on the previous question that wasn't, in my opinion, like addressed appropriately. It's a question about the relationship between religion and mental health and the health system, generally speaking. It can be broken down into general features because religion can be a tool that we can use as medical practitioners. For example, in Sudan, we can involve the stakeholders in rural areas where the religion has a lot to offer, for us, the medical practitioners, as well as for the community. On the opposite side, some patients, they would seek alternative forms of treatment from religious people, and we can like work on trying to provide primary health care and so on and so forth, but they wouldn't reach us, they wouldn't come for us because they're seeking this other form of intervention. So we need to work together to address this issue. Finally, like religion, individual level can form some form of internal conflict. So it can be actually a cause for mental implications and so on. So it's generally a controversy, but I think because of its controversy, we need to address it more and more. Thank you.
Thank you very much. Very, very interesting observations. We are already 5 minutes beyond the time, but since we started a little bit late, I'm going to take 5 more minutes if you have the patience for that. So I'll come back to the panel and ask them to explain one recommendation to a minister, a government, let's not call it Minister of Health because it can be many ministers, for child mental health improvement as well as care that they would like to make for a low or middle income countries. I know that many of you have worked in both countries, high income as well as low, but what's your recommendation for a government to do? And I want just one recommendation from you. You want to begin, Bakar?
Actually, I will give a little bit indirect answer. At least what I'm seeing over here in the last few years and where we were, where we are, and where we are going. Not just for the government, but also people who are involved with this work. It's not an easy work. When I was coming to Qatar, I always used to think of Martin Luther King quote, "I have a dream." So I think one thing which makes the biggest difference, at least in my mind, is having a belief for all of us that anything is possible. So that's the only thing I will say.
So it's not easy, but worth doing. Okay, Agnes.
I will propose to really make it multi-sectorial, but really based on your culture.
Okay.
Because even the question on religion depends where, which religion, which part of the world, but always refer to your society and how you want the person that you want to help have to fit in.
Thank you. Very good reminder that think globally but apply locally and remember culture and your setting. Slav.
My recommendation will be choose your experts and consultants carefully. They need not to fight for their own interest. They not need to fight for their like a school, scientific school or something like that, and they need to be not very narrow-minded in their particular scientific areas, but also they shouldn't be very broad, knows everything.
Thank you. Very, very key reminder. Choose carefully. Lauren.
My recommendation would be to know what the evidence base is in any given field and go to the local champions, the people in the community that care about that issue, regardless of their degrees, and understand what they need to implement some of those evidence-based treatments, if it's the experts or the supports, but build on the strengths that are there in the community and inject that evidence-based knowledge from the world at large.
Thank you very much. Very key recommendations. So I want to now thank the panel members for sharing their information, knowledge, and experience with us. Let's give them a big round. And to all of you for joining us here and also asking questions and sharing some experience with us. We will continue to think more about it, and hopefully WISH will provide further opportunities to expand on this area of work, which is extremely important. And lastly, I'd like to introduce myself. My name is Shekhar Saxena. I work for the Harvard School of Public Health, and before that I worked for WHO. So thank you for joining, and have a very nice evening.